discussion from Dr. Subramaniam Iyer and also the panelists. I want to make a special mention that I congratulate the organizing team and also the scientific session team head or all the members to choose a topic. There is a diagnostic approach to head and neck lesions in the ENT outpatient department. So I think it's more appropriate to say that the clinical examination is slowly not taking part, not gaining the importance in many occasions. So I think topic, I believe Dr. Subramaniam Iyer and also the panelists will be making a we are going to have a very important and good discussion from the head and the panelists. Thank you. Please go ahead. Over to Dr. Subramaniam.
Thank you very much, sir. Thank you very much. Now, before starting the panel, I was just discussing Deepak, saying that whether it is a bit superfluous to talk about these things now or not, then he also said the same thing, that going back to basics is the most difficult thing when we are all talking about big surgeries and all those things. Just going back to the sort of OPD and thinking what other people will be have to do and tell them what to do is the most difficult thing, because again the crowd is mixed. This talk, then again he pointed out one fact that there are a lot of residents and then they are going to benefit out of this mainly. And then with that belief, I think we can start off. And my again mandate was to just talk about how a patient who comes to the ENT OPD has to be. Dr. Murthy, Vesan Murthy was supposed to be. Okay, so anyway, Deepak couldn't come because of his illness. So we have again, there's nothing, no more people needed than with a varied background of practice now with all these 4 people sitting here. And all are experienced head and neck surgeons. So I think the way I was looking at this, the laryngeal, the cases of head and neck which come to OPD can be broadly brought into these things: laryngeal lesions, oral cavity, which can be pre-malignant or frankly malignant lesions, paranasal sinus lesions which are of the head and neck type of variety, thyroid nodules, neck nodes, and parotid lesions. These are the usual things which come across to us in the ENT OPD. And the questions which is always come to anybody's mind when you see any lesion is this: is it malignant? Is it when needs to do a biopsy? That's a usual question which everybody asks themselves. And what basic investigation should you do? As well as in some patients will insist that you finish off all the investigations here, and then if at all you are being referred also, do all these things. So you should have an idea of what you are going to do in these. So let me take some scenarios of each location and then come back. This is a patient with host. And this is another patient who is a chronic smoker, 10 years, hoarseness 2 months. I told you my questions are really basic. Nothing. When will you do a scopy in a patient with hoarseness? I know that we are talking about routines. There are a lot of places where you don't know to do it immediately. So this is a question: when will you do a scopy? What type of scopy will you prefer to do at present, and is the time duration, this is a 2-month-old hoarseness, does time matter? You can all quickly just be brief so we can cover lots.
First of all, I would like to thank the SZTNAOI committee for inviting me for this panel discussion. And answering the question, when we discuss with the hoarseness, what is the type of hoarseness? Is it progressive, unremitting type of hoarseness? And this type of hoarseness needs to be without any vaccine and baby. That patient has to be evaluated by a proper history and it starts with, for a postgraduate, start with an indirect laryngeal examination. Then if you have a 70-degree scope, Hopkins rod, use that scope to know what is happening in the vocal cord. Is it a superficial lesion, assess the vocal cord mobility and extent of the lesion. Depending on that, we have to move forward.
So based on you can continue. Just whatever comes to your mind, you can tell.
Hoarseness for more than a month would warrant a scoping, like flexible fiber optic endoscopy.
You use flexible fiber optic. Okay.
But I will always do indirect endoscopy first.
How do you do the indirect endoscopy now?
In the OPD.
Yeah. What do you use?
Indirect endoscopy, I did mirror.
Mirror. They just want to get that mirror. You use the mirror to see first. And then you use the flexible scope.
We use a 90-degree or 70-degree rigid.
Rigid Hopkins. Okay. That is what you would suggest. You would do.
We would do that as the first choice in all patients. If the patient has a strong gag or we need to look around corners, then a fiber optic scope is ideal.
Okay. Vidya?
I would do a flexible laryngoscopy. There's two things. One is a teacher, another one is a smoker, and the 2-month duration. So I would counsel him to do a flexible laryngoscopy straight away to assess.
Let me reframe your question. See, you are in an OPD situation. You have indirect laryngoscopy. When will you suggest that this patient should have a flexible or rigid scoping? That is the only place. You see, you need to go from that to that.
So from with the
Very quickly.
with the indirect laryngoscopy, you can visualize some lesion.
Yeah.
Voice box.
Yeah.
When you want to know a bit more deeper.
No. Which cases would you suggest that you do, flexible or Hopkins?
More than 1 month of persistent hoarseness would definitely warrant. We have to rule out malignancy. So more than a duration of the hoarseness would indirect laryngoscopy would not reveal certain lesions.
So definitely a hoarseness more than 1 month. And as Divya said, something which is very unremitting and then continuously progressive, you would like to do a flexible or rigid scoping in the OPD. Am I right? So that point is clear? Oh, that's fine.